Welcome back to the session entitled Country Perspectives. We had a very, I would say, rich panel, part one, where we had presentation from Tanzania and Ethiopia, and we had reflections and interventions from a person with lived experience from Zimbabwe and from India. We will do a similar model in the second part, but of course with different speakers. And we will start by inviting to the podium Dr. Syed Zakir Hussain, who is the line director of the National NCD program of the Ministry of Health and Family Welfare of Bangladesh. Please, Dr. Hussain. Please take your seat. And unfortunately, we were just informed by Dr. Esra Shadnavi of the Ministry of Health of Jordan. She just had to leave for a short while due to a situation she had to handle. We hope to have her back and be part of the panel or a bit later today to give her presentation. So we will excuse her for now, but we will then invite to the stage Dr. Nishimiyama Gat from the Rwanda Biomedical Center, the NCD division. Dr. Gat, please come to the stage. Person with lived experience, we would like to invite Mark Barone from the NCD Forum Brazil, which is actually the NCD Intersectoral Forum of Brazil. Sorry about that. And last but not least, we would like to invite a person with lived experience of type 1 diabetes from Uganda, Christine Nabatansi. Christine, yes, please. Who is also engaged with the Sonia Nabeta Foundation in Uganda. And with that, we will start the session. And as we did with the first country perspective part, we will start with the presentations of the delegates from the Ministries of Health. And we would like to invite you, Dr. Hussain, to come and give your presentations about Bangladesh. Please.
It's neither morning nor afternoon, but it's noon. Good greetings. Assalamu alaikum. I am Professor Syed Zakir Hussain, Professor of Medicine and Line Director Non-Communicable Disease Control, Director General of Health Service under Ministry of Health, Bangladesh. You know that Bangladesh is a country of around 180 million people. And there is around 495 upazila, that is this upazila in the Western country known as county, yeah. But in our country we demarcate it as upazila for better understanding in the next slide. You see the non-communicable disease burden in Bangladesh. Around 71% of the death is related to the NCDs. And leading cause of death is the cardiovascular disease, 34%. And in our country, we are doing this thing through the different operational plan. One of the 38 operational plan under Ministry of Health is the NCD. And this is our upcoming fifth sector program objectives. You see here that to reduce the general objectives to reduce mortality and morbidity from NCD in Bangladesh through strategic strengthening of evidence-based measures for control of risk factors and health service delivery option by early detection and management. And there are some specific objectives to promote development and implementation of effective, integrated, sustainable, and evidence-based public policies for chronic non-communicable disease, their risk factors and determinants. To development and strengthening of capacity for surveillance of chronic non-communicable diseases, their consequences, their risk factors, and impact of public health interventions. To foster, support, and promote social economic conditions that address the determinants of chronic non-communicable diseases and empower people to increase the control over their health. This is a very important part. The people should be engaged with their condition, that people should think that this is his own disease. So he or she have to manage their disease for their own interest. So if people can understand this thing, it will help us a lot. And the STEP survey 2022 showing that 1 in 4 adults in Bangladesh suffering from hypertension and 1 in 10 people around is suffering from diabetes mellitus. You see here the current NCD management model in Bangladesh. We have 495 Upazila in Bangladesh. Right now, 429 Upazila had the NCD corner. That is at the primary health care level at the Upazila health complexes. You see, another health facility in our setting is the community clinic. Around 14,500 community clinics is there. So in community clinic, we do the activities like prevention, early detection, and follow-up. You see in the lower part, there is health worker, community group, community support group. They are from the community, they send the patient to the community clinic. There is the community CHCP, community health care provider is there. Their screening is done by them. When they diagnose a person suffering from hypertension or diabetes, they send this patient to the Upazila health complexes. Here registration, diagnostic confirmation is done, and CD patient registration is done, and basic clinical care with national protocol, health education counseling, follow-up, and referral upward as well as backward referral is there. And this following the WHO PEN protocol. Our project implemented 5 components of the WHO HEARTS package to increase the hypertension treatment and control in Bangladesh. Hypertension and diabetes treatment protocol develops for the primary care settings. Activating Upazila health complexes, you see here is a green book, which every patient got this book, and patient records is maintained and treatment given on this book. And city management model implementation partner, these are the partner, both national and international NGOs and INGOs. They are collaborating with us, and we are doing in the different parts of the country. Registration of the patient and follow-up, we using the simple apps. It's really simple because it took only 20 seconds to register a patient. And during follow-up, it took 13 seconds. So you know the doctors and patient relationship ratio in Bangladesh is 1204 per doctor, and less than 1 there is a sister ratio. So huge burden in these centers faces during service delivery. We monitor the real-time monitoring. We can we can see at the central level as well as in the facilities, the manager can see the activities is going on, what activities is going on. You see the blood pressure control rate is around 55%. And this control rate depends on highest when the medicine supply is uninterrupted. If the medicine supply goes down, this control rate goes down. This is the diabetic patients. This is shown in the simple dashboard. Now I talk about the type 1 diabetes. This is a dedicated type 1 diabetes center in hospital of Bardas. You see, this is going on collaboration of the government and the private sector in Bangladesh, especially the Bardas and the international collaboration, especially the CDIC, LFAC, their continuous support. We run this program in the country. We have another 6, one in the Bardem. I think some of you know the center name in Bangladesh, and another 6 centers going outside the country. And you see here that free, we can give the insulin free around 92% of the patient, and 8% of the patient they buy themselves. I must thank these international partners who collaborate with us. And recently we are piloting the pediatric NCD in our country, and it's going on at 22 facilities of our 2 districts. One is Kishoreganj and another is Bagherhat. And namely, the 6 NCDs is the bronchial asthma, nephrotic syndrome, thalassemia and iron deficiency anemia, type 1 diabetes, congenital heart disease, and epilepsy. We are designing and piloting an evidence-based comprehensive pediatric NCD service delivery model for children and adolescents through government primary healthcare system. See, more than 1.2 million children and adolescents worldwide have type 1 diabetes, with 1.5 lakhs new cases yearly diagnosed. In Bangladesh, incidence was 4.2 per 100,000 children in 2013, highlighting the need for special care. The burden extends beyond prevalence, affecting the socioeconomic factors, healthcare access, and psychosocial well-being. I don't go through this clumsy slide. Actually, the rationale, because at primary health care settings, no service for the pediatric NCD group. That's why we are thinking that it needed, and we are going to did this study. And there is scientific working group visited the different Union Health Complex at the study site. And they did a meeting, and they developed a patient pathway. I don't go through this clumsy slide in detail, but one important thing, the diagnostic challenges. Because these diagnostic establishment patient need to come in a specialized center in the capital of Bangladesh, in Bardem, or in the BSMMU, another medical university in Bangladesh. So that's why this is our challenge. After diagnosing, they will refer to our centers in the primary healthcare setting. From that, they will take their medicine as well as their routine checkup and treatment needed. And if needed, they refer the patient to upwards center. We developed a treatment protocol for 6 NCDs, and also it is protocol uploaded in the government website. And you see the training module for the doctors, nurses, and CMO, and training module for CHCP health worker and family welfare visitors. We also developed a patient book for these 6 NCDs, including type 1 diabetes. SBCC materials developed in local languages use CDs for the patients. And this, we are coordinating with our MIS medicine, and they are incorporating. We are already doing work with them to incorporate it with the open MRS system. National training of the trainers taught program. At district level, doctors, nurses, and swimmer at the Kishoreganj and Bagherhat. This overall our NCD publications. We are publicate and various research and survey around 120, 54 in number guideline protocol, and remaining on the these are the disseminated publications. You know, country is going for non-communicable disease, more focused on the prevention. Prevention strategy, diabetes prevention through religious leader in Bangladesh. These are the things we are doing in Bangladesh at a time. Through our mosque, through the sermons and services in the masjid, mosque, there is a service center. So Imam can bring the people to the service center. They are screened here, and if they diagnose the patient suffering from raised blood pressure or raised blood sugar, they send it to our community clinic. And you know that all over the world, all over the country, we have these mosque is there, and it's easily accessible to the community population. And this program is accepted by the OIC. They are going to implement in the 54 OIC country. Another one is the country-changing diabetes. Our slogan is known and inform. In Bangla, jante hobe, janate hobe. And this is another program, identification of at-risk people by the diabetic risk calculator app is there, and people with diabetes by the random capillary blood sugar monitoring. Another thing is the complication screening through the mobile bank. It will soon start, and 10 cities will be involved initially, and 400 screening per city will be done, and type of risk screening through the glucose checking, HbA1c, lipid checking, albumin creatine ratio, ECG, sonogram, eye, dental, and foot care will be done through this initiative. Another program is the Smart Kids and Smart School program is going on in Bangladesh. We did a study in 15 to 20 years student, around 13 of 1,300 of the participant was there of this age group, and we found that there is 4% of the patient children are diabetic, 11% suffering from high blood pressure, and 18% suffering from obesity. So we like to include this group of population so that they will be in our health tracker. They give input there regarding their daily activities, their sleeping time, screening time, waist hip ratio on this tracker. So we can monitor this patient. We can bring a cohort of around from the year of 12 years to 18 years of age children. So, way forward. Nationalize and expand the type 1 registry, provide free insulin from Bangladesh government to healthcare level, nationalize type 1 diabetes guideline, community awareness on type 1 and type 2 diabetes mellitus, complication screening of type 1 and type 2 involving community healthcare provider, community support group for community awareness as well, and development of national obesity registry in place. Thank you everybody for patience hearing and giving the opportunity, especially thanks to the organizer who inviting me in this World Forum. I must thank them, and again, Assalamu alaikum.
Thank you very much, Dr. Hussain, for a, I would say, a very comprehensive presentation about the NCD and diabetes program and hypertension. We saw that as well in Bangladesh, 175 million people, and of course a very high burden, as we could see. We will invite you, Dr. Gad, to come and make the presentation about Rwanda before we move on with the panel discussion. Yeah, and of course I had to apologize the absence of Dr. Shadnavi on her behalf. Hopefully she will come back later or tomorrow to give her presentation about Jordan. And please, Dr. Gad. Yes.
Good morning, everyone. Good morning. You look like, It's a good afternoon, sir. Good afternoon. Thank you very much. Thank you for the organizers, and thank you for all the partners that may have made this event possible. As you can see, I'm Gad Chimimana. I'm representing Rwanda Biomedical Center. For those who don't know, Rwanda Biomedical Center is an implementing agency. It's the technical agency of the Ministry of Health of Rwanda. So we implement all the activities of the ministry. That's why you see Rwanda Biomedical Center here. Going a little bit through NCDs in Rwanda, normally the mortality attributed to NCDs in Rwanda is around 46%, and the prevalence of diabetes is at 2.9%. Those are the studies from NCD Step Survey of 2022. So they are recent. That's where we stand. For all we are going to talk about, normally for us, we have used the approach of integrating diabetes care into our health system. So it's integrated from the central level until to the primary care, health care level. So all we're going to talk about, it will be about integration and what we have done. And obviously we'll be talking about the challenges and what you're looking forward to in terms of addressing the burden of non-communicable diseases in our country. We have received support from our partners, starting from WDF, who have different phases, which we are in phase 2 and 3. We have those projects running in our country. And I won't be reading the names. You can see the project and what mainly what they are addressing in the country. We have one which is integrating type 1 diabetes care into health systems. The other one is enhancing primary level care and prevention of diabetes and other NCDs. As you can see, it's all about integration. It's all about having diabetes care into our primary health care system. So that's the main goal of these two projects. So we have CDIC, Novo Nordisk, that is supporting our diabetes patients, the young ones, to have access to free insulin, which is really has been great for us, has helped, have saved a lot of lives of our patients. So we are grateful. So we'll be talking what you have achieved in general. I'll go through them, some of the key achievements. It's not everything, They are the key achievements, and then we'll continue. So we have done capacity building. As of now, as we stand, normally in 2023, we have one healthcare providers for every 1,000 people. The WHO recommends 4. So you can understand we are still way behind. And for your knowledge, you have around 2,000 medical doctors, including specialists, only in the country. And our country is 14 million. So you can understand the gaps of healthcare providers we have. So we have trained 100 medical doctors. Normally we train those who are attending and see the patients in every hospital. That's what we do, because as of now, we don't have medical doctors in health centers. So all medical doctors are until the level of the hospitals. From there down means health centers and health posts, we don't have medical doctors. They are run by nurses. So we have trained around 1,300 nurses. Those are the nurses that are working in NCD's clinic, being in the hospital and health centers across all the country. And also we have this model of using community health workers, especially when we health promotion, awareness. But in 3 provinces, we have tried to use community health workers in screening, early detection. And it has really given good results comparing it to other models that we had. So we are looking into it, how we can use them, benefit them, either taking blood sugar, because we have said if a patient can go home and monitor himself or herself, why not someone who is trained? I think it can help more. So we are also looking into that approach to use those community health workers to see how they can help us in dealing with early detection and sensibilization to the population as they feel more comfortable having those community health workers that are from their community, the people they know their culture. So for us, it makes our job a bit easy. So what we have done in terms of decentralization, as I have said, I will show you a graph, maybe, and the slides, but in short, we have managed to decentralize diabetes, type 1 diabetes at 123 health centers out of 163 that we were targeting. Normally, we have 510 health centers. So we have managed to decentralize. For type 2 diabetes and hypertension, normally it's their services are at all health centers across the country. So it's been decentralized. It's been more than 5 years. So it's a good thing. We are starting to see the results. So we have partnered, we have developed the guidelines. We have this electronic medical record that we're developing to improve data quality, patient management, and reporting. As of now, all the hospitals in the country, they have electronic medical records. It's what they use. It's been about a few years back. Most of the health centers, they are still paper-based, but we are developing the system that's under pilot in some areas, which includes all divisions, including NCDs, HIV, and other diseases. So that's what we are referring to. We hope that soon it could be all over the country so that we can have good data quality, patient management system, which will, considering the few health care providers we have, it would speed up a little bit the job, so the workload will be a bit easier without using the paper-based registries. So we've bought different commodities. More than 50% of our health centers are doing HbA1c exam for the diabetes patients. So we have really done well, and improvement in supply chain of our essential and NCDs medicines also, it's something that we have looked into too. So we've conducted various youth camps, obviously to education. One of the gaps we have in the country, it's health literacy in the population. So anything that can improve health literacy, I think it's good for us. So we've managed to conduct youth camps, an average of 355 type 1 diabetes patients with collaboration with Rwanda Diabetes Association every year. We've also looked into creating cooperatives. Why? Because if you see our patient, type 1 diabetes patients, most of them, we have in our country, they drop out of the school because of the conditions, because of maybe the school is not helpful, the medicines. So dropping out of school and needing that money, out of pocket money to supply their needs, it's been a challenge for those patients. So with WDF, we thought it could be good to make some cooperatives so they can generate some money to cover all of those expenses. So we have done it. I think this year, with 10 cooperatives. We are creating more, but as of now, that's what we have, and we are looking into it and strengthening and monitoring to see how it can help those patients to improve their lives. Also, we are doing trainings, vocational training. There are short courses, maybe hairdressing, maybe watering, maybe mechanics, something they can do with their lives after dropping out of school, so that they can have some source of income. So, and as we speak now, 75, the young diabetes patients, they are in those trainings, and I think the first cohort will be graduating in this March, this year. So we are looking into it and see what the future holds for us. Let's hope for that it will be a good one. So as I said, we have insulin that is being provided for diabetes patients, especially those under 25 years in all the country. And also, as I said, it's been really good for us. So I mentioned awareness, not because you may see it as a simple thing, but for us it's a big deal, because in the end, it's what is helping us to mobilize, to involve the local community, the partners, to help us tackling this problem. So normally across the country, we have what we call annual community NCD screening. At least people aged 55 and over, they are being screened for NCDs, mainly hypertension, diabetes, and obesity. It's something that we have been, this is the third year, and it has its own challenges, but we're improving it, and it has given us some improvement, but we are still working on it, obviously, but it's really been good. So we have I know some of you have been in Rwanda, possibly you have what we call car-free day, where 2 times per month in Kigali we have, and other cities of the country, the cars, we are running, we are doing mass sports, we're doing awareness, so including with this annual World Diabetes Day celebration, it has been good because we are invited with many televisions in our country, people are interested, so it's been good in terms of awareness, and we have seen that people are, now you ask people, they know what's the diabetes, what's the hypertension, so it has been a good journey regarding this. Also, we have developed e-learning materials for type 1 diabetes in school, and it's with the Ministry of Education is going to be uploaded on the e-learning platform of all the teachers in the country. So we hope that also is going to help them to access the information and help the children, especially when they are at school, but also when they go back to their community. So it's something we hope to be very positive and to have a positive impact. And we have collaborated with many partners, as mentioned, Life for Richard, and they have provided insulin via Rwanda Diabetes Association for about almost 20 years. So they've been good partners in Rwanda. We have Zipline in Rwanda. Zipline, they use drones, the small drones. I don't know if you know it. Since 2016 in Rwanda, I have that Zipline. They use drones. As of now, all the insulin that we are receiving, they are being distributed to the hospitals using those drones. We used to have the problem of shortage of insulin due to the distribution, not because they are not there, but maybe in the capital they have a lot, in some more areas in the camp they can have them. But now we opted on putting those insulins with Zipline Rwanda, and what they do, it's like when you have a necessity in a given health facility, with less than 30 minutes, they deliver those insulins. So it's been good, it's been running, and it's impressive, and we're grateful for all those partners who have made it possible, and we're looking forward to it. We have other partners, you're reading, I won't be mentioning them, just you can read. So, going through quick the system, as I told you, we have decentralized everything. If you can see the pyramid, it's very clear as the number of the hospitals we have, and how do you point? How do you point? To point. To point. Okay. So, oh, thank you. Yeah. So, as you can see, I was telling you that in the country, the system, we have hospitals up to here, which is have 30 districts. Rwanda is a small country. It's not a big one. It's smaller than Denmark, as you know. So we have 30 districts, and each district have at least one hospital. Some have two, some have three, because we have a lot of hills, so you have to have a lot of hospitals and health facilities so that may be easy to access those facilities. So the health center was telling you all of the NCD service, especially for diabetes, hypertension, they are available up to this level in the community. So it means that everyone can have NCD service at the level of the health center. Here we have community health workers. We have 58,000. We planning to train more so that they can help in curbing the burden of our NCDs. As you can see, 90% of the cases we have are being managed at this level. So we are strengthening this area so that also the quality of service we are giving to these people may be better, not only because it's close, not only because it's cheap, but also in terms of quality, to give them affordable and quality service. So this was the timeline of decentralization I was telling you about. As I said, if you see things in Rwanda, it's a few years back, and if you know the history of my country, you understand why. So if you see things coming like from a few years back, don't be surprised. It's because of the history. So we started the shifting. Up to this date, NCDs were managed by medical doctors. So from here, that's when we started including NCD nurses. And from here, we have moved, you can read. And in this year, in July, that's last year, when we started the centralization of type 1 diabetes, in those 123 centers that I told you. As of now, all the complicated cases are managed at the level of the hospitals. The graphs, I think, have changed a little bit, but it's okay. So these are the patients we have, A being type 1 diabetes or diabetes, and this be the average glycated hemoglobin for our patients with diabetes. So this is a system that we use to monitoring the NCD screening coverage. As of now, the target is to screen these millions of people. As of this time, we have screened these, so we are at the end of until June we have to screen the rest of the patients we have. So about to close, I think I have one slide left. So the challenge, as I mentioned, you can see we have health literacy is still low. People, in some areas, you go there, you talk to them, diabetes, they don't know what's diabetes. They are diagnosed with diabetes, they'll be asking, what's diabetes? What did I do to have this? Is it witchcraft? In Africa, have those sort of things. So we still have that gap of empowering the community in terms of knowledge. So budgetary allocation, obviously, regarding the burden of NCDs we have, especially in diabetes, and the money we have invested in it, really, there is a huge gap that still need to be addressed. As we don't have specialists, we have 4 endocrinologists for 14 million of people. So, better than Uganda, but I don't know if it's comforting, but still, it's low, so it is still a problem in our country. So, diabetic drugs, insulin, other supplies, CGMs, those things, but we don't even talk about CGMs because we don't have them. But other diabetic drugs and insulin, they are really expensive. Not because they are expensive in comparing to Europe, but because of the income of our people. So they are, considering the local context of income in our people, they are really expensive. If you know someone is earning maybe $1 or less per day, and then you're charging in insulin maybe on half of that for the monthly salary, so it's really expensive. So also the complication management, we don't have specialized centers. It's another problem we have. We have done an evaluation. We have high turnover of healthcare providers. You train them, after 2 years, maybe 60% of them, they have moved on with other lives. So you have to train again and involve new people. So it's been really a big challenge, which we are trying to tackle, but it's really complicated. So as we don't have a digitalized health system, whole the country, so the data, it's difficult. Planning without having accurate data, so it's also another challenge. So also it's something we can point out. The last slide is this one. Have seen the challenges, but also what we are doing, and maybe the other things that we haven't said, like research. If you go in Rwanda, you type 1 diabetes in Rwanda. If you are lucky, you find one article, more likely you find nothing. So it's a big challenge, it's a big gap in terms of research to inform our policies to be based on, be data-driven. So we don't have that. And it's also another challenge, maybe not mentioned there. So we are still doing community health workers reform to empower those community health workers, as I showed you, to help us in early detection and awareness in the population. So we are strengthening mass sports and activities, including Car-Free Day, so that we raise awareness in the general public, we involve local leaders and other stakeholders, those who have influence on public opinions, so that we may sensitize about diabetes in the country. We have what we call awareness program at workplace. For the working place, we have discussed with the ministry that in charge of public workers, so that there's a program where we're training at least one person or two at every institution, so that they may help those people, either being for screening or being for other awareness. So it started, and it's across the country too is being established. So NCD survey treatment, we have been establishing some centers, heart centers, kidney transplant centers, which I think we have done some good number of transplant in the country, in King Faisal Hospital, but it's still going on. We have four strategies. This one is to multiplicate the public health, those workers in the health service 4 times in 4 years. It started, and we expect in 4 years to have at least those, we have the numbers we have times 4 in 4 years. It's running. I think they are going for the first year, and we hope it to be as quick as we wish. The other one, we want to integrate some NCD's materials in school programs, so that they may have maybe some basic knowledge about prevention, about NCDs. And also we are piloting the national new then EMR, electronic medical record, which we think that will help us in terms of data, in terms of fostering research and other collaborations. So far, I think that's all I had to say. Thank you very much.
Thank you very much, Dr. Gard. Again, a very comprehensive presentation of a country context. I took note of, or we could take note of, a lot of progress in the NCD program and the specific type 1 diabetes area, but we also noted your slide on challenges. You mentioned about staff attrition, number of endocrinologists, and other factors. And of course, it takes us back to the morning when we heard from the Global Diabetes Compact, the global targets, very big targets, very ambitious targets. But now we've heard from 4 country contexts to see the reality on ground. Before we go to the responses and interventions from the person with lived experience, we could take 1 or 2 questions to Bangladesh and Rwanda. Yes? At least 1 question. Yep. And please introduce yourself and make the question a bit short, please.
My name is Jing Luo, and I'm from the University of Pittsburgh. I have a question for the 2 MOH representatives. I'd like to turn the conversation towards commodities, products, and supplies. Imagine for a second that you are a patient with type 1 diabetes and you're 28 years old. If you go to a government facility in your country, can you get insulin, the delivery device, and a glucometer and test strip for free? If the question is yes, what types of products is available? And if the question is no, how much funds or support would you need from the international donor community, from the Swiss government, from WDF, from NNF or others, to make that a reality? Thank you.
That is a very comprehensive question. We will ask the two ministerial representatives to respond initially, and we can have a longer response and discussion later. Please, Dr. Hossain.
Thank you for these questions. Earlier, I mentioned that we have a dedicated diabetes corner in the central level, that is at the Bardem, and also 6 dedicated diabetes corner throughout the country. They are providing the free insulin with the collaboration of government as well as international agencies. And government facilities, those at the Upajala Health Complex level, we are going to piloting at the 2 Upajala level, 2 district level, 22 facilities. Now we are, it also by the collaboration, we are providing the insulin at this level. But forecasting, regarding your second question, the forecasting, we need to work on it so that I can give your answer comprehensively how much needed support from the global level. Thank you.
Dr. Gard, a quick response.
Thank you very much for the question. It's a difficult one, but I will start saying that for the case of Rwanda, insulin normally it's covered in community. We have what we call community-based health insurance, which is used by 83% of the population. So it's covered, that's one. So you can find it there in the public health facility. It's possible, though they have to pay a long amount of money, but other commodities may be difficult. So talking to that, normally it depends more on these industries that produces medicines, because normally the global south, as they call it, it's not considered as a main market for those industries. So sometimes it's hard to get those medicines. Like in COVID-19 it happened, where we were struggling to get insulin, and it was really a big question. You just, on every door you knock, they tell you, no, the insulin you have there for certain countries. So there are other involved factors that are beyond our control, but as much as we can, we try to advocate and buy them.
Yeah, no, that because we have the panel after lunch, which is focused entirely on the insulin supply. So I think we'll keep those comments for that session. We'll have one more question before we go to the interventions. Yes, behind.
Thank you. My name is Crispin from Rwanda as well. And my question goes to the two ministries. I've heard about integration and trainings and turnover of the healthcare personnel. Is this integration we are talking about, NCDs in general, the representation of type 1 diabetes being too small would not undermine the care of the people living with type 1 diabetes? So do you have a solution, or how can we integrate type 1 diabetes and increase the quality of care?
So a question on integration in the health system. I think that's, we can have a quick response now as well. Dr. Siert, I think you showed in your presentation how you are integrating type 1 care.
Actually, you see that our operational plan originally do not have a focused on type 1 diabetes, but we do a new concept, that is the pediatric NCD, that includes the type 1 diabetes. We are piloting it at 2 different districts at 22 facilities. After that, we can scale up, or we can talk in the policy level to incorporate it. And also you see that in our future plan or way out, there is type 1 diabetes registry, and if we create it, then it will also help us to incorporate it in the level of policy level.
We will allow the two persons with lived experience to bring their interventions to keep more time for the questions before that. Mark Barone, please come to the stage. You represent the Intersectoral NCD Forum of Brazil, but you also have many other engagements. We had asked you to reflect on the ministerial presentations, of course, with also your own history as a person with lived experience of type 1 diabetes, plus your global engagements. Please, an intervention from your side.
Thank you very much, Bent. Thanks for the invitation. It's a pleasure to be here sharing a little bit, but also talking about what has been shared with us during yesterday and today. And so as someone living with type 1 diabetes for 34 years, it is wonderful to hear about the progress in, in different countries in terms of what the organization of the system that is providing more for people living with diabetes who obviously need it continuously, which is key. And I'm very impressed with the countries that presented here before me, the integration, how they are using technology also to make it so more accessible, more available to the population. So from apps to drones to deliver to mobile van and different strategies. So I'm gonna start by sharing a little about myself. So I'm here healthy, speaking in this panel, not only because I had access, but I was very lucky to have access to the medicines, and I'm very lucky to continuously having access to the medicines that I need, the technologies that I need, and also the specialists on type 1 diabetes that I can see that have been assisting me, but also due to being diagnosed in a certain place, which is the city of São Paulo, where I found a diabetes association. The case is ADJ Diabetes Brazil, that provided me diabetes education, provided me opportunities for peer support, provided me the opportunity to go to a diabetes camp that was mentioned also in one of the presentations before me, that is really life-changing for children living with diabetes. And all this, obviously, were some of the several factors that allow me to be here today with you, talking about this topic. And so I invite you to use this QR code to access several of the materials of ADJ Diabetes Brazil. There was the participating member of the Global Coordination Mechanism of WHO on NCDs that was highlighted in last month. So this was just released about a week ago. So, but I was not, not everybody diagnosed with type 1 diabetes in Brazil was lucky as I was, so which motivated me to engage in advocacy movements with ADJ Diabetes Brazil and with several other organizations. So starting in the 2000, so we had many progress in changing policies in Brazil, and also this includes more recently. So from that time, we could have the incorporation of insulins for everybody living with diabetes who needed them, and also strips. But more recently, we also had the incorporation of flash glucose monitoring in one city. Everybody with type 1 diabetes receives flash glucose monitoring in one city of Brazil, and also in some small groups in other small cities would also receive. But also and now we are fighting for the entire country, so for children to receive flash glucose monitoring as well. But also I should mention analog insulins. So more recently, analog insulin were also incorporated, but we felt when it was incorporated that it was not a gain, we hadn't gained, we had lost actually the fight, because there was a clause saying that they would be procured by the Ministry of Health only when they reached the same cost of human insulins, and we thought that they would never then be available. And we were wrong, fortunately, because due to the size of Brazil, we could negotiate the costs and reach the same cost of analogs as of human insulin and analogs. So long-acting and short-acting analogs are available to every individual with type 1 or type 2 diabetes who need them in Brazil nowadays, fortunately. So, now you see a picture of my friend Carla Mello sitting right there, who will speak tomorrow. Not only because she was one of the leading people conducting the studies that show superiority of analogs insulins in Brazil, and also showing the cost effectiveness of flash glucose monitoring in Brazil, but also because she is a person living with type 1 diabetes for 50 years, which unfortunately is very rare in Brazil. I hope in the future we see many people living 50 or more years with type 1 diabetes in Brazil, as Carla does. So here sharing a little bit about what we, some of extra, things that we do in ADJ Diabetes Brazil. Here the Young Leaders in Diabetes program, which has been, we started in 2009. And obviously they receive training to make a difference in their communities, in their society, but we ended up noticing that also they were being able to make a difference in their care as well as becoming a leader. And we developed a model, so who's interested, if you are interested in implementing a similar program in your country, in your organization, we also develop a model that is published of the empowerment ladder. So with the many stages that we see that the leaders can go, and obviously the interventions made for them to climb the empowerment ladder. And in 2017, we started the Forum CCNTs, which is the intersectoral forum of NCCs we call non-communicable conditions / non-communicable diseases, if you prefer, in Brazil, to bring together private, not-for-profit, and public sectors in Brazil in order to identify priorities and collaborate and develop partnerships in order to improve the scenario. So nowadays it is the largest alliance of non-communicable conditions in the country, with over 250 organizations participating, including the Ministry of Health, Secretaries of Health, and industry, associations of people living with, medical societies, etc., etc. Universities, obviously. Obviously, I wouldn't be able to explain everything we do. It is a lot. We have 10 different working groups going deep in different NCC or risk factor, etc. But here, just a glimpse of events. We organize online and in-person events every month, 2 very large every year. And with those events, we bring, again, people with lived experience, medical society, academia, Ministry of Health, in order to discuss the gaps, in order to discuss how to improve the situation in the country, to commit and really to influence policies and programs in the country. In this case, I brought, when we launched it in the country, the T1D Index event. I couldn't deliver my speech without mentioning the meaningful engagement of people with lived experience, in this case with type 1 diabetes, since I have been engaged in different groups about this topic, but especially because I would like to invite you to reflect. When we have discussed this a lot yesterday, today again, but to reflect if what we are doing is truly meaningful engagement. Why? Because what we understand as meaningful engagement is actively incorporation of people with lived experience in all stages of health decision-making processes that affect them. So ensuring they have voice and voting power. It's not just storytelling, which is wonderful, but not just that. So again, nothing about us without us. And unfortunately, most of the invitations are with stigma and prejudice, although they are called to be meaningful engagement. And sometimes they are even disrespectful, powerless, and tokenistic invitations. Although they say they are meaningfully engaging. So my final message is also an invitation. So this material was shared 23 hours ago. It was developed by the symposium of people living with non-communicable conditions in the Global Coordination Mechanism of WHO through several events, several participation of hundreds of people with lived experience, and it's available now. And those are the messages that we plan to take to the high-level meeting to engage not only with UN, but with all member states to make meaningful engagement reality in all the different countries. So you can access through the QR code, and I promise. And also please save the date, because there will be another event regarding meaningful engagement by the symposium on April 24th. And I promise that this is the last QR code that I'm gonna share today, and leave this final message: partnership plus evidence plus lived experience drive the change. Thank you very much.
Thank you very much, Mark. We have been advocating for multi-sectoral engagement for some years now, and this was a brilliant example of a person with lived experience as yourself engaging in national stakeholder mobilization, but also, of course, the global level where we've seen you and met you many times. We started this morning with the Global Diabetes Compact. We had a discussion with the researcher, a global community network. We went on to hear from ministries of health in Tanzania and Ethiopia. We heard from people with lived experience from Zimbabwe and India. We went on to hear from two ministries of health, respectively Bangladesh and Rwanda, and we heard from Brazil. So we have been showing and hearing many country perspectives. But now we will have the final intervention for today before we have the Q&A session, and it's from you, Christine Nabatansi. You are one of the type 1 diabetes warriors of Sonia Nabeta Foundation, and you are from a small village outside the town of Jinja in Uganda. Please, Christine.
Good afternoon, ladies and gentlemen. My name is Christine Nabatanzi, a warrior coordinator, Ginger Type 1 Diabetes Clinic, Ginger General Hospital. I'm here to talk about Type 1 Diabetes Country Perspective, Uganda. About Uganda, Uganda is my country. Uganda is the pearl of Africa, coined by Winston Churchill. Landlocked country located in East Africa. Home of Lake Victoria, the second largest lake in the world. The source of River Nile, with diverse ecosystems such as savanna, forests, and mountains. Rich with ethnic groups, with 50 ethnic groups such as Baganda, Basoga, Ateso, and Amuganda by tribe. English is our official language. Luganda and Kiswahili are widely spoken. Agriculture is our backbone, and economy, such as coffee, cotton, and tea, as our major exports. Population in Uganda. Nearly 47 million people. Youth bulge. A half of the population in Uganda is under 17 years old, and 22% is between 18 and 30 years old, and are among that range. Poverty rate is 4%, measured at $2 per day international poverty line, according to World Bank 2024. Majority of the population lives in rural areas. Uganda's healthcare system. We have 5 levels of care. From the smallest, we have community health service, and it is worked upon by the village health teams. We have health centers, district hospitals, regional referral hospital, and I'm working with Sonia Nabeta Foundation at the regional referral hospital in Jinja, and the national referral hospital. Uganda's doctors-patient ratio and nurse-patient ratio is approximately 1 to 25,000 and 1 to 11,000 respectively. What does it mean? It means 1 doctor to 25,000 people and 1 nurse to 11,000 people. Type 1 diabetes in Uganda. Data is hard to find. International Diabetes Federation estimated more than 3,000 children and adolescents with type 1 diabetes. According to type 1 diabetes index, 26% of children in Uganda develop type 1 diabetes and never diagnosed. What does it mean? They die before reaching to the hospital. Insulin for children is available via 2 donations, such as Novo Nordisk or Changing Diabetes in Uganda, and Eli Lilly or Life for a Child. SNF operates 35 clinics for nearly 4,500 children to access that insulin. Type 1 diabetes care and support programs. Type 1 diabetes management in Uganda. Children managed on basal bolus, insulin regimen using short-acting, such as Actrapid, and intermediate-acting insulin, such as NPH or Insultad. Like me, I use Actrapid and Insultad. Daily insulin through insulin pen, and blood glucose monitoring via a glucometer. Daily fingerprints to check for a blood glucose. My experience as a warrior coordinator at Jinja Regional Referral Hospital. We serve 131 warriors. Nearly 75% come from poor and vulnerable background. 20 warriors were newly diagnosed in 2024. 349 A1C tests administered. 51 home visits were conducted. A1C suddenly remains 11.8%. Challenges faced by warriors in Uganda. We have economic stability, poverty. Our warriors in Uganda are very poor. They come from poor backgrounds. We have education. They are illiterate. They cannot interpret diabetic management instructions. We have community, such as isolation, discrimination, and stigmatization. We have home environment. Home environment, poor storage of the insulin, and also they are abused at home, also in the environment. We have food. How can you get insulin without food? Our warriors, they spend less than 3 sleepless nights without food. We have healthcare systems. In Uganda, you have only 4 pediatric endocrinologists, so it becomes difficult for these warriors to access to the specialists. Impacts on clinical outcomes. Social factors. As I spoke before, we have economic instability, unsupportive home environment, low education, food insecurity, community and social isolation, cultural misconception. These social factors leads to psychosocial factors. The social leads to psychosocial factors to the warrior, such as fear, depression, hopelessness, exhaustion, and mental health weakness. So when this warrior becomes exhausted, it leads to individual behavior. So he becomes I'm tired. He hates the life. He becomes non-compliance. So when he becomes non-compliance, like he refuses to take the insulin, he ends up getting poor clinical outcomes, such as poor glycemic control, premature death, and complications. We at SNF believe in an Africa where children with type 1 diabetes have an equal chance at long, healthy, productive, and gainful life. Where in an Africa, a child with type 1 diabetes will never have a challenge because of lack of insulin, poverty, and stigma in the community. These are some of the warriors who are supported by SNF. And most of these warriors come from poor and vulnerable backgrounds. Type 1 diabetes should never get in the way of a child's dream. Thank you for this opportunity.
Thank you very much, Christine. I know you said when we met this morning that you were a little bit nervous speaking in front of an audience, but I think you came out in a very strong and clear way. Thank you very much. Questions to the panel, please. Yes, we will open for questions for the entire session, and even if there are questions to the previous sessions. Please, yes, James.
Thank you. My question's for Christine. Thank you so much for sharing a little bit more about the context in Uganda. I'm interested to hear some stories or reflections about how you feel your role as a peer coordinator has helped maybe an individual or another warrior improve their outcomes or overcome some of the challenges you outlined. If you have an example of your interaction with another warrior, I would love to hear it.
I beg your question, please.
Just an example of how, as a warrior coordinator, you have maybe helped another warrior improve living with type 1 diabetes.
Yeah. At my clinic, I had a warrior who wanted to kill himself because he was isolated, discriminated. At home, they were poor. So I encouraged this warrior not to lose hope. There is future because at Sonia and Abeta Foundation, they provide with us insulin, education, always through camps. So through the guidance I gave that warrior, he gained hope and he's still alive again.
Yes, please. Next question, Jean-Claude.
Thank you, Ben, and thank you, all the speakers. I noticed two contrasting effects on this session. When the government people spoke, it was lofty, all the programs. When the patients spoke, they received nothing, basically. So my question is, how can low middle income countries start generating resources to manage type 1 diabetes programs rather than depending solely on external resources? And this is important because when you have an A1C in the clinic of 11.9, you are grooming people to die from kidney failure, from heart failure, and to die early, premature mortality. So the government should translate what they are doing to improve diabetes care for type 1 diabetes. How do you intend to do that, those of you who work with government?
Was that a question to a specific panelist, Jean-Claude? All right. Dr. Seard, please. And let's all try to have quick and brief responses and brief questions so that we can have more questions activated. Please.
11.9%, almost 12%. It is the indicator of the, I think it's the mortality. And it is the huge burden to the government because government will handle this patient as you mentioned as such. So awareness building and the patient's control of the diabetes. There's a disease is the person. So he has to take the responsibility to control his or her. Government and other can help the patients. So in this regard, I think the process, all things we are discussed here from previous day till today, we are how to manage this, overcome this process. All the answer is remain here. Thank you.
Dr. Gad, quickly, please, a quick response.
Thank you very much. I think it's a critical question, but I'll just give you some points. One of them, I think we needed to generate data to show the government the burden, the importance of the question we are talking about. Because sometimes our government, as a government, sometimes though we say we are government, sometimes we are not the one who own all the budget of the country. So I think it's those in health sectors, it's our responsibility to make the problem go in the public so that they may know it. But also you have, make awareness, to have to involve those other leaders, those key stakeholders who have influence so that they may join us. It's a collaborative effort. It's not, can be not only be done by the Ministry of Health, should be done by the entire government. Thank you.
And we have a question from Giovanni, please.
So my name is Giovanni Torelli, working with Doctor with Africa QAM. First of all, thank you for your very interesting presentation, for sharing the experiences, also for this comprehensive overview from the countries. I was impressed by one data, by many data, but one which is the high percentage of cure which is given in primary health care. I mean, in Rwanda, you said 90%, in Tanzania, before 80% of the cure for type 1 diabetes is given at primary health care. And for, countries which are mainly rural, this is very, very important because distance is one of the barriers. On the other hand, we know we have a gap in between urban and rural. So gaps not only between low income and high income, but also within the same country. Gap considering personnel, resources, quality of care. So, of course, this applies not only to type 1 diabetes, but also to other diseases. So my question is, which are the strategies? I mean, we heard something about new technology, but for these very expensive diseases where, sustainability is the elephant in the room, which are the strategy we can apply to fill this gap and to have kids from rural areas have access to insulin and whatever he needs?
Okay, maybe I start, he will continue. So the strategy, as I think he explained, he mentioned some of them, including the technology, obviously. But the key thing is to make it, to integrate it in the health system, but also to make sure that it's covered by the, some of the main insurances. For example, we are trying to include all of the maybe insulin and other commodities and the health insurance that's mainly used by the population in the country. That's one of the strategies to people, they pay maybe like 10%, But when they go to health center, they pay only like 10 cents for any health service that they will get that day. So that's one of the strategy, to include it in those packages that will facilitate them to have it affordable. Maybe if you have something to say.
Actually, it needs integration. And we think the important type 1 diabetes is a life-saving treatment. Insulin is the life-saving. So documentation and the person suffering from type 1 diabetes, they should be documented, registered, and their life-saving medication as a whole, insulin should be provided, as well as they should be monitored to the government main system that should be supported by the collaboration of other NGOs and INGOs, so that we can make the life more comfortable of this group of the people. Thank you.
Another question? Yeah, here, Silver. And then after that, you had a question, yes. And while we wait for the question, Mark, you had a comment? Brief comment, please.
Yeah. No, I just like to cite two studies in Brazil. So first of all, I showed something so wonderful about Brazil, the incorporations, etc. But unfortunately, one study shows that teenagers from 13 to 19, 30% of them have one or more complications in the country. So we are not doing the good job that we would like to be doing yet. We hope it changes soon. But also there is another study showing that we should truly invest in diabetes care and quality care, because a person with diabetes, there are two, one in type 1 and one in type 2, but they are very similar. 2 years after developing a complications, they cost to the system almost 30 times what cost the treatment, the care before the complication. So it is better to invest in good quality care.
We have the microphone. Oh, we have the microphone. Yes, Silva, please.
Thanks very much.
Introduce yourself, please.
Silva Bahendeka from Kampala, East African Diabetes Study Group. This is to any of the people who have been talking about integration, that's the government. I'm not an economist, but integration means that at the bottom line, you must sit together and do the budgeting for the people you have. Now, from my understanding of the health financing of the primary health care, it's, for example, malaria comes as a package from the Ministry of Health or Ministry of Finance down to the ground level. The same with tuberculosis, the same with other NCDs, but exclude diabetes and hypertension. So how do you unpackage that package which is downline, that is already streamed, earmarked for patients they look at the primary health care with your diabetes patients? Because you can't sit at the same table for a budget for one who has already had earmarked money.
Please direct your question to one of the panelists.
The person from Bangladesh.
Okay, Dr. Syed, please. And we have the microphone to Simon. So we have the next
Thank
question
you.
ready.
Policymakers should understand the necessity of this or importance of this disease, type 1 diabetes. It's a life-saving, insulin is life-saving treatment of them. So they should have a data, they have. So how we can gather? We can gather this data. If we make a registry, there is a type 1 registry. Upon that, they can allocate the budget, and it also need interministerial coordination for allocation. As you already mentioned, the finance ministry is there, and other social ministry, religious, also multiple stakeholders within the government, and including the patient of the type 1. They also very much important stakeholder. By collaborating of this group, if we understand and we committed in a single line, same page, that we have to address this thing. That's why more budget will come here and it will be properly utilized. And utilization is another of the important factor for the low income or middle income country, low middle income country, you know that. So proper utilization of the budget is another challenges. I think with multiple collaboration, we can overcome this thing. Thank you.
Thank you. And Simon, please. And
Simon
introduce
Gabich.
yourself, yes?
Simon Gabich is NCD Alliance, Georgia. I have a question to Dr. Gad. You mentioned that you operate cooperatives to generate incomes for patients with type 1 diabetes. And it's a very interesting approach, but I wonder, can you tell us more details about it, how this cooperative operates, what kind of jobs these people do, and whether it's the promising approach at all? Can you tell me more about it?
A brief response, please, if you can summarize it. Dr. Gad, please.
Okay, thank you very much. So the cooperatives, the type 1 diabetes patients together where they come from, they make smaller cooperative, maybe 10 to 20 people. We involve local government and we involve also the nurses who are attending them to be part of the directors. So it depends on what they do for living in that area. That's where they make their cooperatives. It may be farming, it may be other things, but that really may be having cattle or other things that they do in their normal lives. That's what they invest in their cooperatives.
Yes, okay, we have already exceeded time by 10-15 minutes. Lunch is already ready. We'll take 4 more questions. It will be you, Ubukuyu, it will be Anna Mukumbi, Bovmik from Bangladesh, and Emma. And I'm sorry we'll have to conclude, but we will have more time for questions later. Anna, please start. Yes, Anna Mukumbi.
Thank you, Anna Mukumbi.
And let's be very brief in the questions and to one panelist.
Very brief. To Christine, just to congratulate her on touching us all. I think that there is a mismatch sometimes between what the patients see as indicators of success and happiness and the system. Back to one of the questions that was made. It seems all roses in the ministry because it's just numbers, while for patients, it's their life. And I think that we need to bridge this difference. So thank you so much. The second one is an elephant in the room regarding integration. Integration, it's this very philosophical concept that we all talk about, but that in practice has no procedures or standard operational procedures. And I think that, back to your question, in countries such as ours, mine and Christine's, there is a big difference because we wanting to do integration and what exists in the ground. Each NGO having its own program, its own way of getting into the system, very complicated to put everybody working together, and this also turns into a difficulty for the patients themselves. Thank you.
Thank you very much. So it was a comment as well, Dr. Anna, correct? Dr. Buguye, please.
And mine is also a comment following
Excellent.
what
Thank you very much.
Bendeka said.
Make it brief, please.
And I want to share with the groups. First of all, at PHC, it is already integrated. There's no specialist at PHC. So you have a clinician, you have a doctor, you have a nurse who is giving a service as a whole. So by design, it is integrated. And with the budget, Professor Bendeka, is we as technocrats, we are not planning for that. There is a budget officers, our secretaries who are doing the budgeting. So what we come up with is one, burden of the disease and intervention that we think works. The planning itself is bottom-up approach. It is not the ministry which is prescribing. It is facility. Giving you top 10 conditions, these are the intervention, and this is a budget. So at the ministerial level, when we have colleagues like WDF, USAID, you name it, as a partners, we say these interventions are already covered by these partners and these are empty. So we are using the overall budget allocating for those areas which we have gaps. So don't afraid to plan, especially at PHC. The system accommodates all the bottlenecks that we see at this particular time. But otherwise, the PHC by itself, by its design, it is already integrated.
We have a session in the afternoon about health system reform and silos, and we will continue that discussion tomorrow. And now, Professor Bhowmik, please, Bangladesh.
So I'm Professor Bhowmik from Bangladesh. I'm working with also with the NCDCs. I want to add 1 or 2 lines with Professor Zakir. It's because we are talking about the type 1 diabetes, access to insulin. It is the human rights. So, that the government should give the important priority on the access to insulins. I'm from Bangladesh. The healthcare budget currently is big enough to, to tackle the giving the free insulin and all the tools, the glucometer tool from their budgets. But your responsibility to find out and give the proper scenario to the governments and convince them and force them to change the policy. Within the budget, we can afford to manage all the the type 1 insulins. But the number is only 9,000. So it is the time to totally agree with the change from the Cameroons. So it is the time to take actions from our own budgets. So this is the message to from my side to the governments, the representatives from the Uganda and in Bangladesh.
Thank you, Professor Bhowmik. And the final question will be with Emma on that side, and then we will have the final responses and we will close the session and go for lunch. Emma, please, and just introduce yourself.
Emma Clateman, Life for a Child. This question is directed to Dr. Hossein. Thank you so much for your presentation. Did you learn anything new from Christine or Mark's interventions? And if you did, is there scope for it to inspire you to implement new approaches locally?
Please, Dr. Seard.
Actually, please, can you repeat this question?
The question was that you heard the presentations from Christine and Mark in the panel about programs that are being implemented in Uganda and Brazil, and whether those interventions gave you new thoughts about the programs or new inspiration to some activities or programs in Bangladesh in your context, or even comparing the Bangladesh with what you heard.
Okay, we will think about consideration their approaches they are practicing in their context. I also work with this their experience and try to customize in our context, and we will also assess the applicability of in our context. If it is feasible, we will think in our context too.
And that was actually a very nice way of concluding, because when we started the morning, we informed about the QR code here, which will be a permanent website with all the presentations, all the material we have collected for this conference, whereby every participant and everybody who will be in this network can access these materials. Learnings from Brazil, learnings from Uganda, programs from Bangladesh, from Rwanda, and all the other presentations we will accumulate into the website and hopefully strengthen the network. With that, we'll give a round of applause to the panel.